visions at all levels. But halos, glare, dysphotopsia remains a problem because of these out of focus images. Now, despite so many evolution and despite so many promising IOLs, sometimes our patients still, why all cataract surgeons are not doing 100% presbyopic surgeries, because sometimes the patient will complain of problem in the visual acuity, sometimes the contrast is a problem, there could be an occasional glare and halos, and you spend so much time and effort and money, and the patient says that, nah, in our North India, they said, maza nahi aaya, So this is a challenge for the cataract surgeon, that how to do all your cataract surgery as a cataract refractive surgery. So we started from the era of refractive multifocal, where the refractive rings caused the simultaneous vision, but then it had its own limitation in terms of, loss of contrast sensitivity, being pupil dependent, being very sensitive to centration, and hence the evolution to the diffractive multifocal IOLs. Now here the principle is to use diffractive rings, the physical steps on the IOL, which creates the multifocality, dividing the light into various zones, and there have been a lot of modifications where we've gone from apodized to non-apodized to changing the height and width of the ring, and the aim is always be able to give you a continuous range of vision with a better utilization so that the energy is better. So just an example of how even the trifocals have evolved over a period of time, and different companies promise you different technology. So, you get confused when you're starting with presbyopic IOLs. There are so many options, and every other day the MR would be sitting in your OPD, and every MR's lens is the best. So this is just to give you an overview that these are the common diffractive trifocal IOLs, and the other are the extended depth of focus or the extended range of vision CRV kind of lenses. So just to know that this is what we have in our hand as a spectrum. So I've picked up few common lenses to give you an understanding on how they work. So for example, Alcon Panoptic works on a diffractive trifocal technology. It uses the fourth zone it has combined into the first to give better light utilization, and hence it's called an enlightened optical technology to give better contrast. It gives excellent near vision and also in distance and intermediate. So similarly, Zeiss also works on the trifocal principle, which has two distinct additional focal points for intermediate and near distance. And most of the lenses are now, by the virtue of how their diffractive rings are in the center, are becoming more and more pupil independent. But of course, in the pre-examination, as Dr. Rishi said, we do also have to look at pupil size to see how it works in the mesopic conditions. Another popular lens, it's by J&J. It's a Synergy. It's called Synergy because it combines what they have learned from their previous two lenses. So they had a multifocal refractive and they had a Symphony, and we know the problem with Symphony, how our patients could not really read N5 and very close, and there was a top up or a micro myopia advised in other eyes, the micro monovision. So they've combined these two technologies to give a continuous range of vision, and they have also added something called as chrome-li, which is reducing the chromatic aberration to improve the overall contrast sensitivity. Then there are some new lenses which has come as hybrid lenses. Basically, the outer platform is a refractive platform for distance vision, and the center is an aspheric surface for near and intermediate distance, also promising continuous range of vision. Another lens is the mini-well lens. This has caused spherical aberration in the central 3 mm of IOL, and we know with the spherical aberrations, if the light are focused at different foci, it just gives you an extended depth of focus lens. So, and again they have modifications. If they feel that their lenses are not doing well for near, they have a mini-well proxa for the non-dominant near vision, and asking for combination of their regular and proxa lenses. The new kid on the block, a very popular lens by Alcon now, is Vivity. It works on a different principle of X-wave technology. So here there are two smooth transition elements in the center zone of the pupil, and within this zone there is a 1 micron elevated plateau. So all this stretches your wavefront and shifts the line onto an extended focal length. So the advantage of Vivity is that it doesn't have those multiple diffractive rings, so it doesn't give that much of glare and halos. It's just got a central bump which you can see on the lens, and this is also working very well for distance, near and intermediate vision. Because it doesn't have diffractive ring, it doesn't decrease the contrast sensitivity. So one thing which you can be very sure of with a Vivity lens is that your distance vision is not going to get compromised, so you're not scared that the patient will have problem. A safer bet wherever you cannot use presbyopic lens is now something called as enhanced monofocal. So you have an IOLs, which is a Technis J&J platform, and the Ray1 IOL. Basically, it's a refractive lens with a continuous power profile created with higher order spherical anterior surface. The power is increasing continuously from the periphery to the center without any steps or zone. So this looks like a monofocal lens. There are no rings, there is no central bump, and it just simulates extended depth of focus by the virtue of how the power is distributed over the lens. It gives you distance and intermediate, doesn't really give you a close read up. So if your patient doesn't fall into the category of other presbyopic IOL for various reasons, ocular reasons and other reasons, then this is a safe bet which you can choose from. Last but not the least, our old gold, monovision standard. We are talking about cataract refractive surgery, and if the patient is not falling into the category of any kind of presbyopic lens, then, and if the patient is also keen that he wants to decrease the dependence on glasses, then we've always done this. Choose your dominant eye by looking, which eye is dominant, correct them for distance, and the other eye, depending on what he wants, near or intermediate more, you leave a residual of 1.5 or 2.5 depending. So I would say, since we are doing this session for, general ophthalmologists who are transitioning to cataract refractive, it's very important to choose the initial cases. You don't want to have a bad, unsatisfied patient and then you get disheartened and don't do more of these lenses. So choose a hyper presbyopic. These are extremely grateful people because, they've already been struggling with their plus for near. Whatever comes out, even if there's a small residual error, they're extremely happy patients. Choose patients with less than 0.5 astigmatism because most of the lenses are forgiving for that much astigmatism. Anything more, Dr. Harshul's talk is there on how to manage astigmatism for presbyopic IOL. You will have to go to toric and other means. So that's a transition. First, be comfortable with presbyopic, choose lesser astigmatism and go with that. Preferably bilateral because the neural adaptation is always much better. If you do one eye presbyopic or diffractive lens and the other is not, there is a bit of struggle in the neural adaptation. And of course, as we know that the ocular screening, like two things which every presbyopic IOL or a premium IOL planning needs is a corneal topography and a macular OCT. So you create a cataract package the way we charge our biometry, incorporate topo and OCT in it, and your optom should know that a presbyopic IOL and premium IOL need that kinds. So now, just with that kind of overview that you have that many lenses options, which lens would you want to choose from? So as pointed out earlier, it's very important to understand the patient's lifestyle, work, need, understand their comfort for paying. See, they are paying more. And if they are not 100% satisfied with what they get, you're going to have a very unhappy patient and you'll spend a lot of chair time. So never push a patient beyond their means. We have Indian lenses also. We have other options that we have discussed. Go for that. Establish a predictable lens. Every MR will come and tell you my lens is the best. So what you do is talk to your colleagues who've been in presbyopic IOL. I did that few years back when I transitioned to this stage. Talk to your colleagues, let them make the mistakes and then you learn from their mistakes. It's always better that way. So look into their lifestyle and profession. Be very cognizant of the fact that what all requirements they need. The sudden change now, see earlier when we did refractive IOLs where we started from many years back was about distance and near. Now you'll realize, especially with the lockdown COVID times, 90%, 80% we are on digital platforms. There's a lot of LED light which we use. So these also become challenging situations for the lenses to adapt to what kind of distances we want to work to. There's a lot of emphasis now in evolution of intraocular lenses on intermediate distance because there's a lot of work being done at that level. So, how to choose the lens when you go back to your OPDs, please make a questionnaire format. There are some standard ones out there. Even the company people give you, the patient sitting in your OPD while he is getting worked up can fill those forms as to what his visual requirements are. Depending, I'm not going to go into detail here because, after the end of the instruction course, we will discuss that what is the patient's requirement. For example, somebody's near work is more or if distance is more, different clinical situations is what we will decide and help you to make a lens. And of course, type A personality who don't want to compromise on their lenses or, the top-up glasses will not be the ideal patient for presbyopic lenses. So these are the conditions which we will be discussing in our post-talk session as to different situations and which and when and how to choose. So, the lenses are still, evolving. We are still to get the best ideal lens, but the idea of this AC is to give you a sense of what best we can do in the current armamentarium and how to give best results to your patients. Thank you.